So, hope all of you have done well in your exams. And please remember, this recall session is obtained purely from the inputs from our students. So there might be some errors or less adequate clarities in the questions or images. So don't worry. So this is basically intended for improving or for those who are aiming for the upcoming exams like INI, which is coming in next 2 months and for next NEET. So don't worry after seeing the result answers which are discussed in this session. So as usually, we had around 15 to 16 questions from radiology, and these questions were not purely radiological. As we all know, radiology doesn't have a self-existence as usual. It will be always combined with medicine or surgery or any other subjects. So here, this time also, the questions were previous year question-based questions, and most of them will be were of moderate to easy to moderate or moderate to tough, like difficulty levels. Okay, so don't worry. So we will see question, and I will start with my favorite question, because usually whenever I am teaching you radiology, I always tell you can always expect one question from ankylosing spondylitis. Also, you can also expect one question from bariums like this achalasia cardia. Every exam from 2018, if you see, you will definitely get one question from ankylosing spondylitis. Here, this time also they had a question. In history, the patient had back stiffness, anterior uveitis, and in X-ray, the finding was not that evident. So what is the investigation that help you to diagnose ankylosing spondylitis at the earliest? That is the one easy, frequently asked one. And in always I used to tell stir MRA, stir MRA, stir MRA will be the first investigation. So the answer here is MRA SA joints. Okay, sir. Actually, it's a pretty straightforward one. MRA will be the investigation that help you to make the diagnosis of ankylosing spondylitis at the earliest. So that is actually pretty straightforward one, which we already discussed multiple times in our class or in our workbooks. Okay. Now, another question, again, achalasia or CA esophagus like question. Here today, some of the students were telling that there was a history of weight loss was there. So I usually tell whenever, whether it is an achalasia or a carcinoma esophagus, you will definitely have weight loss because dysphagia is there. The patient is not able to eat something. But when there is a history of bronchiectasis, you have to think in terms of connective tissue disorders like scleroderma. The connective tissue disorders like scleroderma, which can have bronchiectasis or lung fibrosis, will usually be associated with achalasia cardia. And many of them were telling that the image was classical for achalasia. They had a bird peak like smooth tapering. So if it is a rat tail like tapering or narrowing, then it could be CA esophagus. So if the image was of achalasia, then the answer will be manometry. And if the image was that of a carcinoma esophagus, then it will be biopsy. Okay, then it will be upper G endoscopy and biopsy. So it will totally depend upon the image that is given. But if there is history of bronchiectasis or any other connective tissue disorder, then it is more towards achalasia. So that is the concept. So that could be achalasia. So if it is achalasia, then the answer, we have to see whether there is primary peristalsis is present or not. So you have to go for manometry. So if any one of you are having any doubts, please you can let me know in the chat box. Okay. Now, then there was a question regarding a 33-year-old female with lower abdominal discomfort and bleeding like that. And an MRI image was given. And from the description given by the students, I could understand that there was some lesion in the posterior myometrium. So this is the posterior myometrium, which were having some cyst-like areas. So when you are seeing an image of a posterior myometrial lesion or an anterior myometrial lesion with these cystic-like areas, then it could be an adenomyosis. Okay. In our class, we discussed how to differentiate between a fibroid and an adenomyotic uterus. In fibroid, what happens? You will be able to see very homogeneous T2 hypointense lesions. It will be very homogeneous, ball-like or round-like. But when it comes to adenomyosis, what happens is there will be thickening of the junctional zone. There will be thickening of the junctional zone and multiple cyst-like areas will be there. So if you are able to see thickening of the junctional zone with multiple cyst-like areas, then that could represent adenomyosis. So this question also, the answer will completely depend upon the image that is given. So if that image had thickening of the junctional zone with the cystic areas, then it could be adenomyosis. Or if the image was very T2 hypointensity uniform like that, then it could be fibroid. Okay, so in our gynecological session, we discussed how to differentiate between a fibroid and adenomyosis in MRI. So this could be either adenomyosis or fibroid. I think it will be adenomyosis because most of the students were telling like the image was a heterogeneous image with multiple cystic areas inside. Now, whenever I am teaching radiology, I used to tell in my class that CNS radiology is the most important one. Okay, CNS radiology, because you will be getting a lot of questions from CNS radiology. We know that. And this was another classical spotter which came in the exam. So a 30-year-old male or female with complaints of headache, MRI brain is given. And there was a mass lesion like this showing the dural tail. So when you are seeing the dural tail, you have to be sure that you are dealing with an extra lesion, that is a meningioma. So dural tail sign, mother-in-law sign, all these are signs which you see in meningioma. So this could represent a case of meningioma. So if it is an ependymoma, it should be an intraventricular lesion. Glioma will be butterfly shape, butterfly glioma or white matter infiltrating lesions like that. So this is a case of meningioma. Another straightforward one. Another one question which they asked regarding intravenous urogram is, they asked you to find out the correct statement. So, intravenous urogram, we already discussed how we are doing that. We will simply inject contrast and take X-rays. This is how you do IVU. So, can you tell whether it is an invasive investigation or non-invasive investigation? Definitely, it is not at all an invasive investigation. You will simply give some contrast and take multiple X-rays. So, that is a non-invasive investigation. And no, none of these non-invasive investigations can be gold standard, because gold standard is something which is both therapeutic and diagnostic. It is an invasive investigation. So you can easily rule out with our simple logic and common sense, you can easily rule out all these things and you can find out that IVU is a non-invasive investigation. You can diagnose PUG obstruction. Yeah, you can make so many diagnoses with IVU. PUG obstruction is one condition which you can diagnose with the help of intravenous urogram. So this could be the answer. It is a non-invasive investigation that you can diagnose with the help of intravenous urogram. Now, this is something that we usually don't discuss in the class, because usually this question, we usually keep it in our question bank or in our exams or T&D like that. So some pulsatile lesions, and when imaging is done, you are able to see the classical lyre sign. Lyre is a musical instrument. So actually, this is the splaying of internal carotid artery and external carotid artery by the tumor. So in the exam, if this exact same image is given, most of them were telling that the lyre sign was seen, then this could be a carotid body tumor. Okay, then this could be a carotid body tumor. So carotid body tumor is seen in old age people. So it is chemodactoma, another name for carotid body tumor. What it does is, it will splay the internal and external carotid artery. So if this image was given, then there is no doubt that the answer is carotid body tumor. Another very common question which usually comes up in the exam is pediatric hip. So there are three differentials. A patient is an obese 13 or 14-year-old child, then it could be a CFE. Okay. If the patient is a young child with difficulty in walking, and if you're able to see there is fragmentation or sclerosis of the epiphyseal region, then that is the avascular necrosis, also called as the Perthes disease. Avascular necrosis, also called as the Perthes disease. And DDH is something that is common in females. You should be able to differentiate between these three conditions. So if in the image there is a destroyed or sclerotic epiphysis which is reduced in volume is given, then the answer will be Perthes disease, that is idiopathic avascular necrosis of femoral head. Okay, that is the concept. So this is another repeat question that usually comes out in exams. Now, the next one is actually quite interesting, because whenever we discuss respiratory system, we will start discussing by telling about conditions that can result in volume gain, volume loss, and no change in volume. So we know routinely in our clinical practice, we will be coming across consolidation, collapse, pleural effusion like things, or pneumothorax like things. So you should know how to differentiate all these things. So that is some basic. And this question here, the patient had high grade fever and cough. So when a patient presents with the fever and cough, clinically you know that you are dealing with pneumonia or consolidation. So you should pick up a good amount of idea from the history itself. So the patient is coming to you with high grade fever and cough. And when you see, some of them were telling that there was air bronchogram. If there is air bronchogram, then it is consolidation for sure. But some of them were telling that there was a good amount of tracheal shift towards one side. So if there is a significant tracheal shift, because a mild amount of tracheal shift towards right side is a normal. You know, trachea can be mildly shifted towards right side in a good number of common or normal population. But if the tracheal shift is significant, then it could be collapse. But if the tracheal shift is very minimal and you are able to see air bronchogram or homogeneous opacity, then it will go in favor of consolidation. Okay, so that is the concept. So this answer also will entirely depend upon the image that is given. If you are able to see air bronchogram within that, then the answer will be consolidation or pneumonia. But if you are able to see volume loss or fissural displacement with the tracheal shift, then it could be collapse. Okay. So most of them were telling that the tracheal displacement was very minimal, air bronchogram was seen. So if air bronchogram is seen, then it is consolidation. If there is no air bronchogram, but you are able to see there is volume loss and tracheal pull towards the side, then it could be collapse. So that is the concept. So you have to remember that. Now, another very important thing which usually comes in every exam is to identify the difference between spondylolisthesis, spondylitis, like that. Since these wordings can be extremely confusing, it can create a confusion among the students. Okay, that is the key concept. So most of the people were telling that there was a anterior displacement of the vertebral body. So if there is anterior displacement of the vertebral body, then there is no doubt that is spondylolisthesis. That is, vertebra is anteriorly moving. So that is called as listhesis. So if there is anterior displacement, then this is listhesis. But only if there is a pars defect like this, then it could be spondylolysis. So, but most of the people were telling that there was anterior displacement. So if there is anterior displacement, then it is spondylolisthesis. That is the concept. So this is another one thing which we commonly discuss when we are discussing musculoskeletal radiology. Okay. So you should know the difference between listhesis. In listhesis, what happens? There is movement of vertebral body. But in spondylolysis, there is only fracture of pars intermedia. There is no displacement. That is the difference between listhesis and lysis. Spondylitis is infection. Okay, you don't need to worry about that. So this is another thing. Now, another pediatric question, which this is another very favorite area for examiners. It can be a mixture of questions from neonatology. Neonatology is very important from pediatric side. Radiological imaging of pediatric radiography is another important thing. So a 24-hour-old neonate, that is 1 day old neonate with respiratory distress. So usually when a patient, when the history of 1 day is given, you should think about the common things. So this image is classical for CDH, that is congenital diaphragmatic hernia. You can see there is a displacement of bowel loops from the abdominal cavity into the thorax. So this is classical for congenital diaphragmatic hernia. CPAM can, that is congenital pulmonary airway malformation, can be a confusing thing, but usually the patient will not show distress on the first day of the birth. So when the history is very important. See, there is no self-existence for radiology in entrance exam. So what happens is you have to always rely on the history. So when you are given a case of a 1 day old child with his respiratory distress, you should think about the common things that you can see. So CDH, that is congenital diaphragmatic hernia, that to the Borchdale type, is a very commonly encoded condition. Okay, so that is the concept. So this could be congenital diaphragmatic hernia. Now, another important thing that we usually discuss in our class is a patient coming to you after RTA. His GCS is very poor. CT brain you are taking, you are expecting very big bleeds. You are not seeing any EDH or SDH or SAH. The CT brain appears normal. So this is actually a condition that we discuss in our class. when you discuss neuroradiology, when you discuss the basics of radiology, thumb rules of radiology, all these things. So what is the answer? So this is actually the condition called as diffuse axonal injury, usually which is not seen in CT, you need MRI. Usually previously they used to ask which sequence is required to image ADAI. Usually we will rely upon susceptibility weighted images to find out diffuse axonal injury. This is another commonly discussed case scenario. Always I am telling you again and again, neuroradiology is very, very important. Okay, because every year you will get so many questions. From last year also, there were around 10 questions from neuroradiology. This year also, if you see, this is one question. This is another question. A patient with atrial fibrillation who present to you with a sudden onset of one-sided weakness. CT brain you took, but CT brain is normal because the time period is only 2 hours. Because in first 2 hours, you know that CT will be normal in these patients. So what is the next step? So clinically, the patient is having atrial fibrillation, so he is prone for embolism. You know this is a case of infarct or CVA. So what do you have to do? There is no role for carotid Doppler, no role for this transesophageal echocardiography, no for LMWH. What is the thing? You have to go for thrombolysis. Okay. So thrombolysis is the management. What is the role of CT? CT will tell you whether it is a ischemic infarct or a hemorrhagic infarct. CT appears normal. There is no hemorrhage. So you are free to go for thrombolysis. That is the basic principle behind stroke imaging. If you are getting if one option is there to go for DWMRI, then it could be confusing. But here, luckily, there is no option of MRI. So you can go for thrombolysis. That is the concept here. I hope this is a very straightforward, easy one, which is actually, this is not purely radiological. You know, this is medicine, neurology plus radiology. Another question, which this is actually again last year also there was a similar question. A child with growth disturbance or visual disturbance, and there is a suprasellar mass with a cystic area. Last year also in 2024 also the exact same question was repeated. So when you are seeing a suprasellar mass in a pediatric age group, the answer is one and all craniopharyngioma. And histopathology is given. Okay, I'm not very confident about the histopathological part. Usually there is a motor oil appearance we tell, but something is given like squamous epithelium with wet keratin. You can refer that in pathology, but here there is no doubt that this is a case of craniopharyngioma. If there is a cystic lesion with calcification, if you're seeing a cystic lesion with the calcification in pediatric age group in suprasellar region, again and again in our book we will tell in suprasellar region, because we have seen this question again and again. So this is a case of craniopharyngioma. Okay. Now, another question. Again, a patient with hearing loss, imbalance, present to you. MRI shows cerebellopontine mass. And histology is beautifully given. Antony A, B bodies. So what is the answer? So when you are seeing a CP angle mass, and this Antony A or B verrucae bodies, the answer is again straightforward. That could be a vestibular schwannoma. Another repeat question from neuroradiology. Okay, again, they have just mentioned the importance of CP angle masses. And if you see, we have already seen that this mass will be having the typical ice cream cone type of appearance. Okay, this will be having the typical ice cream cone type of appearance. Now, again, a case from ENT side. A teenage patient. Okay, whenever we discuss about teenage patient with epistaxis, we know in entrance exams the answer is one and only JNA, juvenile nasopharyngeal angiofibroma. And here in the question it was given that there was an enhancing lesion in posterior choana like this. Okay, enhancing lesion in posterior choana, and it can compress the wall of maxillary sinus. What is the sign called as? It is called as the Hallman-Muller sign. Okay, this Hallman-Muller sign. Okay. So all these things will direct towards the juvenile nasopharyngeal angiofibroma. Another straightforward question, actually not purely radiological, not purely clinical. That is a clinico-radiological mixture of question that you can expect in the present scenario. Okay, this is the type of questions that you can expect in the present scenario. So this is a case of juvenile nasopharyngeal angiofibroma. Now, another question, this question can be this can be also confusing because a patient is having respiratory distress after surgery. So patient is developing respiratory distress after surgery. His respiratory rate is high, his pulse rate is high. So what is the most appropriate management? Okay. So you could, because you know this is a case of pulmonary thromboembolism, so you can get confused whether you have to go for D-dimer. See, they are asking you most appropriate. If they're asking you the first investigation, you can go for D-dimer. But if they're asking you most appropriate, then that should be something that will help you to clutch the diagnosis. Then definitely the answer will be CT pulmonary angiogram, because CT pulmonary angiogram will tell you whether there is a thrombus is sitting there or not. Okay. So gold standard, if you want to confirm pulmonary thromboembolism, the investigation of choice will be CT angiography. The investigation of choice will be CT angiography. So that is the concept. So if the question, if in the question they are asking you what is the first investigation, you can go for a chest radiograph or D-dimer. That could be different. But if they're asking you the most appropriate, if the question contains the word terminology most appropriate, the answer will be CT pulmonary angiogram. That is the concept. Now, a patient with a history of right-sided flank pain. Actually, this is another controversy, because some of them were telling that in the image GB was not seen, kidney was not seen. So I'm not sure. But most of them were telling that there is a history of flank pain. So when you are seeing a case with the history of flank pain, this could be either because only in renal pathologies we will be telling about the flank. So if the lesion, actually this is an anatomy based question. Only if you see the image, you can tell whether it is a GB mass or a liver mass or a renal cell carcinoma. So, but since there is a flank is included, and many of them were telling that the kidney was seen and the upper pole of kidney, there was an heterogeneous lesion. I think that could be a renal cell carcinoma, but again, I'm telling, so if you are seeing this review, don't get disheartened, because I'm not sure. No one can be 100% sure that this is a RCC or GB mass. If you are able to see GB like this, then it could be a GB mass. Okay. So only thing is, you have to stick on with the history. If the history contain anything like jaundice or something, definitely it could be a GB mass. If the history had hematuria or flank pain, then it could be more of a renal cell carcinoma. So this is another question that heavily relies on history and the anatomical site. Okay, anatomical site. Now, this is something that we haven't discussed in our routine classes. Actually, many of them thought that this is a plain image. Some of them are telling that this is a barium image. Okay. So if this is a barium image, then the first thing that you see is called as the vallicula. And the second thing that you see here, this is the pyriform sinus, or pyriform fossa, you can say. The first thing that you see is called as the vallicula, and the second thing that you see is called as the pyriform sinus. Okay, that is the concept, is the pyriform sinus. Okay, so this is the concept. So most of them are telling that they were pointing it at the pyriform sinus. So if the arrow is at the second level, then it is pyriform sinus. And one again straightforward question, a 2-month-old pregnant woman, what is the best parameter that help you to date the pregnancy? So in first trimester, the most important parameter that helps you to date the pregnancy is always the crown rump length. We have discussed this again and again. Actually, this is a gynecological radio question. So in first trimester, it is always the crown rump length. In second trimester, you can go for BPD. Okay, so that is the concept. In first trimester, it is always crown rump length. So these are the questions which has been asked from radiology side. So there were around 18 to 19 questions, and most of the questions we were able to discuss that in our classes, also in our workbook and in our question bank. Also, most of these questions were there. So I hope all of you have done well. Anyway, all of you have given very much so much hard work in this last 1.5 years. So now it's time for you to take good rest, relax for a month. Okay. Anyway, I wish you all the best for the results. Let the results come. So don't get panic or don't get unnecessary stress by seeing these reviews, because or any of these answers could be changed according to the change in the question phrasing or change in the images. So don't worry about these things. Be happy. And actually this recall is meant for people who are preparing for the upcoming exam. That is the take home. Okay. So all the best, guys. I wish you all the very good luck. Thank you.